Artificial Intelligence Doctor, www.abcpharma.net/English user question. What are the long-term effects of pacing from different right ventricular sites on the progression of ventricular remodeling and heart failure in patients with LBBB, particularly in relation to changes in QRS duration and ventricular activation? Plot AI answer. This is an excellent and complex question that touches on several important aspects of cardiac electrophysiology, pacing, and heart failure progression. To address this comprehensively, let's break it down into key components. Right ventricular pacing sites. The most common sites for leadless pacemaker implantation in the right ventricle, RV, are RV apex, RV septum, mid or high, RV outflow tract. Long-term effects on ventricular remodeling. A. RV apical pacing, traditionally associated with more adverse remodeling, can lead to left ventricular, LV, dilation and asymmetric hypertrophy. May exacerbate LV dysynchrony in LBBB patients. B. RV septal pacing, potentially less detrimental than apical pacing, may result in more physiological activation patterns, could lead to less adverse remodeling over time. C. RV outflow tract pacing, may offer a compromise between apical and septal pacing. Effects on long-term remodeling are less well established. Impact on QRS duration. RV apical pacing typically results in the widest QRS complexes. Septal pacing may lead to narrower QRS complexes compared to apical pacing. The degree of QRS widening may correlate with the extent of ventricular dysynchrony. Ventricular activation patterns. RV apical pacing creates a left bundle branch block-like activation pattern. Septal pacing may result in more synchronous activation of the ventricles. The activation pattern influences mechanical synchrony and efficiency. Progression of heart failure. More desynchronous activation, wider QRS, is generally associated with faster progression of heart failure. The degree of ventricular remodeling often correlates with heart failure progression. Pacing-induced cardiomyopathy is a recognized complication, particularly with RV apical pacing. Specific considerations for LBBB patients. LBBB patients already have altered ventricular activation. RV pacing may compound existing dysynchrony or, in some cases, partially mitigate it. The interaction between intrinsic LBBB conduction and paced activation is complex. Long-term outcomes to consider. Changes in left ventricular ejection fraction, LVEF, development or progression of mitral regurgitation, frequency of heart failure hospitalizations, overall mortality rates, quality of life metrics, potential mitigating factors, percentage of ventricular pacing. Higher percentage may lead to more remodeling. Use of algorithms to promote intrinsic conduction when possible. Individual patient factors, e.g., underlying cardiac substrate, comorbidities. Research challenges. Long-term studies, 5 to 10 years or more, are needed to fully assess these effects. Controlling for confounding factors in a complex patient population is difficult. The evolving technology of leadless pacemakers may impact long-term results. Future directions. Development of leadless pacing systems capable of multi-site pacing. Integration of more sophisticated algorithms to optimize pacing based on individual patient physiology. Potential for combining leadless RV pacing with other therapies, e.g., LV pacing, in select patients. In conclusion, the long-term effects of pacing from different RV sites in LBBB patients are likely to be significant but variable. Generally, pacing sites that produce more physiological activation patterns and narrower QRS complexes may lead to less adverse remodeling and slower progression of heart failure. However, individual patient factors play a crucial role, and more long-term data specific to leadless pacemakers in this population is needed. Ongoing research in this area is crucial to optimize pacing strategies and improve long-term outcomes for patients with LBBB requiring ventricular pacing.